Okay, let's start our session. I hope you are doing well. CBC and the other one is clear to you. Liver function test and the CBC, right? And the foundation. Okay, so welcome to the module number 4. I will be briefing you what is coming in the session for 5-10 minutes, and then I will be sharing slides. Okay. I hope till this module you don't have any question, query, doubt, confusion. If you have, you can feel free to drop message in the WhatsApp. Also, we have this group for us only. If you are seeing the recorded session later as well, and you have doubt, feel free to drop the message. Okay, serious questions are welcome. You can ping me in the in person also. I will be there. I'm just a message away, right? So understand the concept clarity because nobody is talking about laboratory medicine. Okay, so I hope now you also recognize the pattern of understanding that what we are discussing. We are not only discussing the laboratory parameters and what is the reference range and what does it indicates, but we are linking it to the clinical scenarios. We are discussing the cases as well, and we are making a connection between the clinical judgment and the laboratory things. Right. So, welcome to this module number 4, guys, of the laboratory medicine. And this lecture is on renal function test. As I earlier told you, LFT and RFT, these two things are very, very important while handling cases. You must know, even if you want to advise the alternative therapies, even if you want to check the therapeutic effectiveness of the therapy, whatever your roles and responsibility as in clinical pharmacist or pharmacist you are handling, in everything you need to correlate patient's renal function test, liver function test, as the first pass metabolism is related to the liver. 95% of your drugs are going to be metabolized by the liver, and 95% of your medicines are going to extract, excretion is going through the kidney. So renal function tests are very important. So this lecture is on RFT. Also with the RFT, you will be having the understanding related to the electrolytes, acid-base disorders, which is very important again, ABG disorders. We will see these ABG disorders using some, atrial blood gas analysis. Commonly, it is called as ABG. So this is one of the most important modules I will consider in this whole laboratory medicine course, in the renal, because in the renal clinical practice, especially in an cases of an emergency, ICU, ward rounds, these are the labs, these are the reports that decide whole dose adjustments, emergency management and patient survival as well. And that is why I will consider this module as one of the most important for from the whole laboratory medicine course. And by the end of this session, I want you to feel confident, not scared of these RFT reports. So when you see next time renal function test reports, electrolyte panels, or ABG reports, you will be feeling more confident. That is my learning objective behind this whole, putting this session in front of you. I hope it is clear to you what is coming in the session. Is it? I will also provide access to unmute yourself if you want to speak at the end, right? You can just raise the query. Is it clear to you what is coming in the session? Yes, yes. Okay. I will also advise you to please have notes with you. Okay. Whatever concept might be new to you, you can note it down. I can show you guys the direction. This is the online platform, right? So I will say some disadvantages of this online things is there. Please note it down. Ask later. Okay. Uh, After 1 month also you can raise a question. No worry, right? But ask and note it down because you will be having exam also next week, so you must remember all the concepts, right? So if something is new to you, something is out of your understanding, note it down, research about it, try to figure out what is happening. So this is how you can evolve, and you can also understand the concept in detail. Okay, let me share the screen with you and we will be having it. Just a minute. I hope the screen is visible to you guys. Is it? Yes. Okay. Okay, thank you so much for your reply. Just a minute. Here. Okay, say this. This is the title of renal function test, electrolytes and acid-base disorder. You will be also having a link that why I have included these three things all together in one module by the end of the session. You will be seeing what is the relation also. Okay, let's start this module by understanding the reason behind it. We will be seeing why, we will be seeing learning objective, and then we will start the session. Okay, I hope the title is clear to you that what is RFT, renal function test, electrolyte, acid base disorders. Because as I earlier told you, this is one of the most important modules I will consider because in case of emergency, ICU, ward rounds, these are the lab reports that decides the whole picture, okay, whole picture of your therapy. It is deciding the dose of antibiotics the patient is receiving. It is deciding if the patient's own survival, and it is deciding the I will say what will be the treatment approach. Okay, so all the things are based on these reports, and that is making this module very very important. So why, we will start with why this module. Just give me a minute, guys, give me a minute, just a minute. Okay, let's start with why. Okay, why this module matters to us. So why gives you the importance, right? So importance should be clear to you why we are learning RFT and all. Many of you might be already aware ki yes, 90 to 95% of drugs are being excreted from the kidney route. We must be aware of RFT. So let's first understand why this topic making sense and what is the importance this topic is holding. The kidney is, I will say, it is not just an organ for the urine formation, guys, right? It is not an organ for just the production of the urine, but it is responsible for removing whole waste products from your body. It is maintaining also the fluid balance. It is regulating your electrolytes as well. Ultimately it is controlling all acid base balance, right? So almost every critically ill patient, whether it is a case of sepsis, whether it is a case of diabetic emergencies, whether it is case of cardiac failure, this will show abnormal RFT, abnormal electrolytes. So as a future pharmacist, your role is crucial here because many drugs are nephrotoxic, you know that, right? 95% drugs are having nephrotoxicity profile. Many drugs require renal dose adjustment in case of it is showing imbalanced values. In that case, renal dose adjustment is required, and many electrolyte imbalance can be drug induced as well. So the role of pharmacist is very huge. That is the reason behind putting this module in front of you. So you are not just reading the numbers here, you are preventing the harm if you are learning RFT in detail. So you must be knowing the kidney regulation, you must be knowing the critical care relevance and the role of pharmacist. I hope now you are able to connect that why we are learning RFT, electrolytes and all. So let's understand first the learning objectives behind this whole session. Learning objective gives you idea about by the end of this session what you will able to understand. So by the end of this session today, you should be able and you will be definitely be able to interpret RFT. Okay, so RFT interpret करना बहुत important है, right? Renal function test क्या दिखाता है, what it indicates. So interpretation, of course, we will be going to cover. Also, by the end of this session, you will be able to clearly understand what does blood urea nitrogen is all about. Okay, creatinine, what does creatinine actually mean? Okay, so understand the electrolytes also to be able to identify the stages of acute kidney injury, abbreviations related to whole AKI. Also, you will be able to recognize some of the commonest electrolyte disorders. Interpret, you will be also able to interpret ABG reports step by step. I will let you know how to do it. And by the end of this session, you will be also able to apply all this knowledge to a real clinical case, whether the case is diabetic ketoacidosis or maybe AKI, hyperkalemia, all the cases we are going to discuss today. to summarize and to connect all the doubts. Okay, connect all the points. So this is not a theory lecture. Let me give you a disclaimer. This will be a clinical application, guys. Okay, how to read RFT, electrolyte, and ABG report, and how to apply it in a clinical setting. This is the lecture about it, and that is the reason behind I have put the course title as in laboratory medicine and not only the laboratory interpretation. Okay, otherwise I can have the course also on the interpretation only. So we will be talking about reference range in normal ranges and all. Okay, but this is not the way. I am assuming little bit that you are aware of the normal range, and now we are correlating everything in the clinical setting. Okay, because we are it is very easy to remember normal ranges while you are handling cases on a daily basis. It is not that hard. What is the hard part is to correlate it with the clinical setting. This is hard step, and that's the reason why I have come up with this particular course which relate laboratory things with your medicine practice. Okay, so let's start with the very first section. We have four different sections to understand in this, particularly the whole module. Very first section, we will understand RFT. Okay, so what comes under RFT, guys? What comes under the RFT? So when doctor says renal function test, they usually mean, the panel of test. Like it is not a single test. Okay, not just one value. They need a panel. So renal test includes these things. You can see here the bullet points: blood urea nitrogen, abbreviated as the BUN. Then we have creatinine, that is serum creatinine. Then we have eGFR, that is estimated glomerular filtration rate. And clinically, we need a urine output as well. Okay, so the common mistake students make here is focusing only on the creatinine or the eGFR. But in reality, creatinine alone never tells the full story. Just give me a minute, guys. Just a minute. So creatinine alone cannot tell you the whole story, but we need, lots of things altogether to assess this thing. Just a minute. Okay. Uh, okay. So sorry for the disturbance. Yes. So what comes under RFT? We have BUN, we have creatinine, we have EFR, EGFR, and we have urine output. And the commonest mistake students are making is focusing only on one or two parameters and ignoring others. But in reality, we need to connect all the points all together and to make the any clinical judgment. Is the screen is visible? Is it visible to you? Yes, I think some technical glitches are there today. I hope it is visible now. Just a minute, just a minute. I'm facing some technical glitch. Yes. So we were talking about what comes under this renal function test, and we need to correlate everything all together for the clinical judgment. We need every parameter, okay, in the renal function tests. We'll start with the BUN, and we will proceed with the serum creatinine, eGFR, and the urine output, and we will try to connect all the dots, okay. So first we will start with the BUN, that is blood urea nitrogen. So let's start with this very important parameter in the RFT. This is the urea. This is showing you the urea deposition. Urea is actually formed in the liver, from the protein metabolism, and it is excreted by the kidney. That is what the mechanism is. I hope you guys have idea about it. It is made, it is formed in the liver, and it is secreted and excreted by the kidneys. So the normal BUN range is written here. See this 7 to 20 mg per dl is the normal range for the BUN approximately. It is in the milligrams per deciliter it is written. And important point here is to understand BUN is influenced by many type of non-renal factors also. So it is not always associated with the renal things, but it is affecting whole renal function because it is excreted by the kidneys. So protein metabolism is making sense now. So you need to understand that urea is formed in the liver, by the protein metabolism, the steps, and excreted by the kidneys. Normal range is 7 to 20 in between, and BUN is influenced by non-renal factors as well. Some you can understand high protein diet all the time. If the patient is not moving, the exercise, lack of exercise is there, physical activity is less, and only taking high protein diet. So BUN can, that is non-renal factor because protein metabolism has immense role. Also, dehydration is the reason. It is also a non-renal factor. And GI bleeding is not written here, but for your understanding, I am telling you that BUN is also influenced by gastrointestinal bleeding as well. So increased BUN does not always mean the kidney failure because it is influenced by non-renal factors as well. तो अगर नेक्स्ट टाइम हम BUN देख के बोलेंगे कि yes it is having some problem with the kidney, no, we need something more to check the renal function test. But yes, it is one of the factor to consider. Okay, one of the factors to take consideration on. I hope it is clear to you because you must be aware of some non-renal factors that influence the blood urea nitrogen. If it is increasing, some non-renal factors are also playing a huge role in the BUN, such as this high protein diet, dehydration, and GI bleeding, right? So please understand, BUN alone does not mean the kidney failure. I will be having some of the cases for you so that you can connect. Now, let's understand serum creatinine. Now, this is very important, and this has different range related to male and female also, different ranges for male and female. So let's talk about serum creatinine. This is very important RFT parameter. Creatinine is produced from what? It is produced from muscle metabolism, right? Muscle metabolism and excreted by the kidneys. So BUN was produced from the protein metabolism in the liver and excreted by the kidneys. Same serum creatinine was produced in the muscle, I will say in the metabolism pathways, and later it will be excreted by the kidneys. So it is a late marker, guys. It is a late marker according to the age and the muscle mass as well. Okay, so you cannot always, again, serum creatinine is one of the big factor to consider all the time, but it is a late marker of the kidney damage. So it is very important. See, this normal range for the male approximately is 0.7 to 1.3, and female is having approximately 0.7 to 1.1. Difference is very less, but still male and female has different range as per the classification. But the key concept you need to remember here is creatine is late marker of the kidney damage. So by the time creatinine rises, significant nephrons loss has already been occurred, एंड वो हो गया होगा तब आपको क्रिएटिनिन ज्यादा मिलेगा, राइट? सो बाय द टाइम क्रिएटिनिन rises, significant nephron loss has already been occurred. So also remember all the time, elderly patients may have normal serum creatinine despite of poor kidney function, guys. This is contraindicatory. Please understand, elderly patients में बहुत बार ऐसा होगा कि आपको पुअर किडनी फंक्शन होगा, स्टिल उनका क्रिएटिनिन जो है वो नॉर्मल रहेगा, या फिर सेम एग्जैक्ट ऑपोजिट सिचुएशन भी हो सकती है, गुड किडनी फंक्शन विथ altered serum creatinine, because they have low muscle mass, because elderly population has low muscle mass. This serum creatinine is all about muscle metabolism. It is excreted by the kidney, but it is a late marker. These are the fundamental things you need to be aware of related to serum creatinine, right? Now, BUN and creatinine ratio you need to be aware of. Both has ratio as well. So this ratio helps to differentiate types of the kidney injury. What type of kidney injury a person is having. So BUN GEM creatinine ratio is telling you that what type of kidney injury the person is having. Normal BUN to creatinine ratio is 10 to 20 is to 1. Okay. 10 to 20 is BUN. GEM, it is 1. That is the creatinine ratio. If the ratio is high, like about 20, think of the pre-renal causes, guys. Think of pre-renal causes, like it can be dehydration or some type of shock, right? We have types of shocks as well. So, for an example is also written for the better understanding. If the patient with the severe vomiting, understand, patient with severe vomiting has BUN 60 and the creatinine 1.2. Now, this suggests clear thing about the ratio will be about 20. So that is the dehydration case, not intrinsic kidney damage, right? So this is how you can link it and you can differentiate the type of kidney injury, like whether this is exactly the kidney injury or no, right? So BUN to creatinine ratio you need to be aware of. If the ratio is high, think of pre-renal cause. Pre-renal means before it reached to the renal, and before it reaches to the renal, it can be the result behind the dehydration and the shock, right? So severe vomiting वाले केस में ये बहुत ज्यादा common होता है. So you can correlate while handling BUN and creatinine ratio. You must be aware of this thing, right? So first BUN, second creatinine, third is ratio you must be aware of, and these are simple topic of the discussion. Now, EGFR. Now, everyone has the idea that how important it is to estimate this glomerular filtration rate. Estimated GFR is very important. And why it is important? So, let's come to the most important parameter, this EGFR, right? And, to consider this is very important. And this estimates how well the kidneys are filtering blood. And that is what exactly showing you that what is the capacity of the kidney to filter the blood and to excrete the waste product from it. If this is fluctuating, you can directly tell that the person is suffering from any kind of injury related to the kidney, right? So EGFR estimates how well the kidneys are filtering the blood. The advantages are written here. This EGFR is more accurate than creatinine alone. As you know, creatinine is the late marker, guys, and it is also associated with the muscle mass, right? So, of course, EGFR is more accurate than the serum creatinine alone. We need to correlate both of the values. It is also having the advantage that it is having accounts for all the age, all the gender out there, and all the body size. We have classification according to it, that what should be EGFR range, right? And it is also used for the drug dose adjustment. We need to be aware of the calculation of EGFR based on the what the patient is having, the EGFR. Based on that we can do a drug dose adjustment as well. So whenever you see EGFR next time, think of, can I safely give this drug or not? And you need to calculate it. I will let you know how to do it. There is a one simple formula for it, and which you can apply. As for hepatic, I told you the Child-Pugh criteria was there. ऐसे ही एक फॉर्मूला इसके लिए है कॉक्रॉफ करके, that you can use for the EGFR based calculation for the drug dose adjustment for the renal impairment cases, right? But this is the parameter which is giving you the idea about the kidney's health, the actual kidney health. And based on EGFR, we have classification of chronic kidney disease staging. Okay, stage 1, stage 2, 3, 4, 5. So we have stages as well as we have types as well as, all depend on EGFR. Let's understand how they are classifying it. Say this, we have CKD stages with us. So based on estimated glomerular filtration rate, chronic kidney disease is further stage from stage 1, 2, 3, 4, 5 here, which is written. You can see here stage 1 to 5. If the EGFR is greater than or equal to 90, that is suggesting the normal kidney function. If it is stage 2, it is between 60 to 89. Stage 3 is 30 to 59. Stage 4 is 15 to 29. And if it is less than 15, it is the end stage renal disease, ESRD. And many chances of the renal failure as well, right? So many antibiotics, anti-diabetics, antivirals need the dose reduction from the stage 3 onwards. Please understand. Stage 3 agar aa raha hai EGFR, then many common drugs, okay, many common drugs like antibiotics, anti-diabetics, antivirals need dose adjustment if the patient is having EGFR range between 30 to 59. right? So they cannot take the normal dose as per the normal adult dose, right? They cannot take it because of EGFR is suggesting the poor kidney health directly. Okay, let's understand it by the disease specific so that the more idea will be clear to you. Let's understand AKI, which is an acute kidney injury. Okay, it is an acute stage, so you can understand what is acute does mean. So let's talk about this AKI, which is abbreviated as the AK, acute kidney injury is abbreviated as an AKI. And this means a sudden decline in the kidney function, guys. It is a sudden decline in the kidney function over hours to days. Over hours to days में sudden decline होता है in the kidney function, and it is diagnosed by what? Rising in the creatinine and the urine output. Okay, creatinine is sudden increase, and urine output is suddenly reduction, right? So AKI is extremely common in the hospitalized patient and the ICU patient as well. Suddenly creatinine will be increased, suddenly the urine output may be decreased, right? This is the acute kidney injury. And AKI staging we will be having, so that you can correlate the laboratory parameters with the AKI staging. And this is known as KDIGO. That is very important. Okay. AKI is staged according to this KDIGO guideline. It is a guideline. Okay. It is a guideline which is standard. Okay. Which is the standard for kidney disease. It is the standard for kidney disease improving global outcome. The full form itself, it is having kidney disease improving global outcome. Okay. And according to this, AKI is having a stages, stage 1, 2, 3. Okay. Stage 1 to 3. Stage 1 is a mild increase in creatinine. Stage 2 is moderate increase in creatinine. And stage 3 is severely increase, or, stage 3 indicates a dialysis requirement directly. So why this staging matters as per this kidney disease improving global outcome? Because it can predict the whole prognosis, guys. This is the clinical importance of staging. It can predict the prognosis. It can guide the drug dosing. So in the stage 1, we can go for the mild dose, right? And in stage 3, we can directly put the patient on the dialysis. So this is giving you the idea about the drug dosing, and it is determining the need for the nephrology consult, that what exactly the patient is needed, whether they should visit the nephrologist or no, if the stages is underestimate. So these are the things AKI staging is having, and we have some of the types of AKI as well. So this acute kidney injury classified into three things. We have pre-renal AKI, we have intrinsic AKI, and we have post-renal AKI as well. Now, what do you mean by pre-renal? Pre-renal means reduced blood flow. Reason हमने पहले भी discuss किया in severe cases of vomiting, for an example. So pre-renal में हो सकता है dehydration or heart failure risk, right? Intrinsic AKI, that can have damage to the kidney tissue. Okay, intrinsic AKI, that means damage to the whole kidney tissues internally, right? So that can be the situations like acute tubular, necrosis. Some nephrotoxic drugs like aminoglycosides are directly, triggering this intrinsic AKI, aminoglycosides, right? And post-renal means that can be obstruction, kidney stone, prostate enlargement, and those type of cases. So pharmacist must always suspect ड्रग इंड्यूस इंट्रिंसिक एकेआई. हम फोकस करने वाला है सेकंड नंबर की बुलेट पॉइंट पे, विच इज एन इंट्रिंसिक टाइप ऑफ द AKI. As I already told you, one of the example, nephrotoxic drugs like aminoglycosides are directly damaging kidney into the intrinsic level. Okay, so you need to be aware of this. So in the cases of renal function test, guys, you must be aware of BUN. You must be aware of creatinine. You need to be aware of BUN and creatinine ratio. And the fourth you need to aware of, that is the EGFR. EGFR, how it is helping us to differentiate the stages, how it is important for classification, how it is important for the drug dosing. I will be having case to discuss this thing, so don't worry. But first, let's understand this section 2, which is the electrolyte disorders. Now, what are the key electrolytes we are having? So we have the 4 key electrolytes we will be focusing on. We have sodium, that is Na plus, we have potassium, K plus, we have chloride, right? Cl, and we have HCO3, that is bicarbonate. So these four are very important. Even small changes in this, values of this electrolyte, that can cause लाइफ थ्रेटनिंग कॉम्प्लिकेशंस. ये कभी भी हम यस थोड़ा सा भी चेंज इसमें बैर नहीं हो सकता. Sodium, potassium chloride, and bicarbonate. Apart from this, also we have multiple electrolytes to focus on, but these are some of the key electrolytes. Okay, so very first is the sodium. So we will be discussing sodium disorder in the next slide. Then we will be discussing potassium disorder, and this then we will be discussing about ECG changes in the hyperkalemia, and then in one slide we will be having chloride and bicarbonate, right? So let's start with the sodium disorder, guys. नॉर्मल सोडियम रेंज, आई होप यू हैव आइडिया अबाउट नॉर्मल सोडियम रेंज. बहुत ही ज्यादा कॉमन है इन केसेस ऑफ ऑल हाइपरटेंशन पेशेंट. यू मस्ट चेक द सोडियम थिंग्स, राइट? सो नॉर्मल सोडियम range is 135 to 145. That is the reason why I have not included in the slide, because I think many of you already aware of this sodium range, right? At least 135 to 145 मिली इक्विवेलेंट पर लीटर के रेंज में आता है ये, ठीक है? मिली इक्विवेलेंट पर लीटर 135 to 145. दो चीजें हो सकती है. देयर आर टू पॉसिबिलिटी ऑफ द सोडियम डिसऑर्डर्स, हाइपोनेट्रेमिया एंड सेकेंड इज हाइपरनेट्रेमिया. या तो कम हो सकता है या तो बढ़ सकता है. Hyponatremia means the low sodium. Of course, the name itself has meaning. What are the causes? So you will be surprised to know some of the diuretics. Of course, it is antihypertensive, so it will lower the sodium, right? Diuretics, some of your SIADH. What do you mean by SIADH? Syndrome of inappropriate antidiuretic hormone. I'm again repeating, if the term is new for you, you can note it down. Syndrome of inappropriate antidiuretic hormone. This is the syndrome, means the group of symptoms occurs because of inappropriate use of antidiuretic, inappropriate use of diuretics, which is causing antidiuretic hormone irregulation. So that is also the reason behind hyponatremia. And the symptoms are very common. Slight confusion can start, and it can go up to seizure as well, coma as well. Okay, so this is a very big issue related to the sodium. So we must be aware of this thing, right? Confusion से लेके seizure तक उसका symptom हो सकता है hyponatremia का, right? Next thing we have, that is the hyper. That means the higher sodium. So this is usually due to of what? Dehydration, right? Hypernatremia means high sodium, usually due to dehydration, and it is causing altering, all the mental status. So this kind of symptoms associated with the hypernatremia. These are the sodium disorders, guys, that you must be aware of. 135, 145, okay? 135 to 145 milliequivalent per liter is the normal range for the sodium. Next we have, that is the potassium disorders. Now potassium is most dangerous electrolyte, I will consider. Potassium is the most dangerous electrolyte I will consider. Normal range, I hope you might be having idea about potassium normal range. It is 3.5 to 5. 3 to 5, okay? So generally I remember as in 3 to 5, but ideally as per guideline it is 3.5 exactly to 5 milliequivalent per liter. And again we will be having two condition, hypokalemia, hyperkalemia. So hypo means the decrease amount, okay, less than or equal to 3.5, that is hypokalemia, borderline you can consider. So due to some uses of prolonged use of diuretics, this can be happen. Severe vomiting cases, maybe hypokalemia can be happen, and it cause overall muscular weakness, also arrhythmia, because potassium is required for the continuous heart pattern, right? So basically it is causing a muscle weakness and arrhythmia. And on the another hand, we have hyperkalemia, which is increased potassium, which is very common in the AKI, guys. Now I will let you know how we can correlate these two things, right? Why RFT is discussed with electrolytes. So it is seen in AKI, hyperkalemia, potassium का बढ़ जाना, 5 से ज्यादा बढ़ जाना, that is seen in acute kidney injury. If the patient is using AC inhibitors for the prolonged time, okay, AC inhibitors for the prolonged time for hypertension management, this situation can occur. So this can cause sudden cardiac arrest, guys. So now imagine if the person is already having impaired RFT status. RFT uska already imbalance aaya hai, and if the patient is also having hyperkalemia, they are the at higher risk of cardiac arrest. We must intervene, and there is some treatment related to it. It should be there. Imagine a patient having hypertension, hyperkalemia, and the kidney injury. What will be there? Because hypertension management ke liye hi we are prescribing diuretics and AC inhibitors. And now you have idea that diuretics and AC inhibitors are the responsible for hyperkalemia situation. What can be the alternatives in it? So these type of scenarios are very common in the clinical setting. I will let you know how to solve these things. Don't worry. Just for now, understand why we are correlating all these things all together. Okay. Sodium, potassium. Now understand this hyperkalemia, ECG changes. Okay. Very important. Hyperkalemia. So second situation, right? Hyperkalemia affects the heart, as I earlier told you, that the patients are at high risk of cardiac arrest if they are suffering from hyperkalemia. And please remember, AC inhibitors are responsible to cause hyperkalemia. Oh, okay, so patient is suffering from hypertension, it is at higher risk. Hyperkalemia affects the heart. ECG change include what? You will be having a tall picked T wave. I hope you might be having the idea about the ECG. Okay, tall and peak T wave दिखेगा. You will be having widened QRS complex. QRS complex आपको wide दिखेगा. Eventually, it will be having a sine wave pattern, and this is why potassium values must never be ignored. ये कभी भी इग्नोर करने जैसी बात नहीं, इसलिए मैंने पहले ही बोला कि पोटाशियम जो है वो डेंजरस टाइप ऑफ द इलेक्ट्रोलाइट है गाइस. यू मस्ट बी अवेयर ऑफ एंड वी कैन नॉट इग्नोर इट. Okay, so sodium and potassium. Potassium is associated with this thing. Hyperkalemia में ECG changes आते हैं. ठीक है. Now let's understand chloride and bicarbonate. So chloride usually follows the sodium, guys. And it has directly the acid base link. So I will be correlating it with the ABG. Don't worry in the section 3. But for now, understand chloride usually follows the sodium. Okay. And bicarbonate, which is abbreviated as the HCO3, that reflects metabolic acid base status. Bicarbonate reflects metabolic acid base status. Low bicarbonate, that means metabolic acidosis. I'm again repeating. Low bicarbonate is means metabolic acidosis. Why I have not included lots of theory in the slide? Because I want you to listen to me. Because I want to discuss a lot of things, right? Everything I cannot include in the slides, but you can just focus on the words. And if you are noting it down, very good. Okay. So chloride usually follow what? Sodium. Bicarbonate reflects the metabolic acid base status, guys, and low bicarbonate agar hota hai, that means it is a metabolic acidosis situation which needs further the therapeutic intervention, right? So let's focus on now the ABG, which is the section number 3 to understand. ABG is the arterial blood gas. Now that is very important thing. ABG stands for arterial blood gas analysis. We need to do it, and it is highly associated with all type of parameters. It measures your pH. It measures partial pressure of carbon dioxide, which is abbreviated as a PaCO2. That is partial pressure of carbon dioxide. It is also measures bicarbonate, and it is also measures partial pressure of oxygen, PaO2. Partial pressure of oxygen. Now this ABG, that is arterial blood gas, gives a real-time picture of respiratory and metabolic status. Okay, whole respiratory picture it will show you, and whole metabolic status it will show you, this ABG report. Okay, you might be having idea about it, it might be new to you, but whatever the situation is, please understand this in very detail, because many students has no idea about the ABG things. Okay, so arterial blood gas analysis. This analysis gives you idea about pH, partial pressure of carbon dioxide, partial pressure of oxygen, and bicarbonate level. So it gives a real-time picture of respiratory. Real-time picture means what is the current status. Okay, so real picture of respiratory and metabolic status क्या है वो दिखाता है. Let me give you idea about the normal ABG values. See this is the normal ABG values. Memorize if possible. If no, don't worry, because it will be available on a one single click. So no need to memorize, but need to correlate is very important. Okay, so memorize this value if you can do. pH is having a 7.35 to 7.45. Partial pressure of carbon dioxide is 35 to 45 mmHg. Bicarbonates is 22 to 26 microequivalent per liter, and partial pressure of oxygen is 80 to 100. When you are, handling ABG report continuously, these reference ranges will be stick to you. Okay, it will be clear in your mind. Don't worry. But what is important here is the ABG interpretation. ABG cannot be interprets directly. It always follow this golden rule. Golden rule also you can consider as a golden order. Okay, you must follow this pattern. Very first, you need to understand pH. Second, partial pressure of carbon dioxide, and bicarbonate. Never ever jump randomly. ABG interpretation is always step by step, not a guesswork. Okay, so when you are doing a ABC interpretation stepwise, you will be having a direct interpretation. We will be discussing in next slide how to do it. Very first, step one is the pH analysis. So step one is very important, and it will be assessing the whole pH values. Okay, so you have now the normal range of the pH. pH is 7.35 to 7.45, and if the pH is below 7.35, it will suggesting you acidosis situation. If it is above 7.45, if the pH is this, then it will suggesting you some alkalosis, acid, right? So acidosis and basic, right? Alkalosis. So this is giving you sign about what is the acid status. So first to decide acid or base. That is the very first step of ABG interpretation. Okay, you need to assess pH first. Acidosis, of course, you have idea 1 to 7 and 7 to 14, right? So 7.35 is acidosis. 7.45 से अगर बड़ा हुआ होगा तो it will be alkalosis. Okay, so acid और base का idea एक बार अगर हो जाए, उसके बाद second step आता है, which is primary disorders you need to identify. See this, if low pH is there, low pH is there, okay, and low bicarbonate is there. So that means there will be metabolic acidosis. Bicarbonate is something like basic, right? Basic environment, but basic environment कम है and pH भी कम है. pH कम होना मतलब 1 to 7 में fall होना. That means it is the case of acidosis, but it is metabolic, right? Second, if the low pH is there, pH is low means acidosis, of course it is confirmed, and it is partial pressure of carbon dioxide is high, it is suggesting you respiratory acidosis. Respiratory acidosis. I hope you are able to connect it. Okay. On the contradictory, on the opposite side, if the pH is high, that means alkalosis is there. But if the bicarbonate is also high, okay, it will be metabolic alkalosis. Sorry, metabolic alkalosis. And if the pH is high but low in the pressure, carbon dioxide pressure, it will be showing you a respiratory alkalosis. Now you can shift these things, and you can understand that what will be happen with the low pH and high bicarbonate, high pH and the low bicarbonate, right? So you can understand it simultaneously. It is very easy. But these four are the gold standards to identify the ABG report, to interpret the ABG report. So as I earlier told you, ABG gives you idea about respiratory and metabolic things, right? So first step is understanding the pH analysis. Once the pH is clear to you, you can consider it is acidosis or alkalosis. And by the partial pressure of carbon dioxide, you can examine whether it is the case of respiratory or whether it is the case of metabolic. If it is low PaCO2, pressure is low, respiratory will be there. If the pressure is high, it will be respiratory acidosis with the low pH, right? So you can consider this bicarbonate, you can consider pH, and you can consider partial pressure of carbon dioxide. These three are very important, and these three are here written. So ABG interpretation order, first you need to identify pH. So you will be having acid or base. Then you need to understand partial pressure of carbon dioxide to understand whether it is respiratory related or not. And then you need to understand bicarbonate level to understand the whole concept, right? And you need to interpret this as moderately as possible. Okay, so this is how it is very important and making sense now. So you can relate these things. pH and bicarbonate are somewhat similar, and similar gives the interpretation. Both are low, that means it will be the acidosis situation, right? So this is how you can interpret. I hope it is clear to you. Is it? May I know some reactions and all? Yes. Okay. Thank you so much. Okay. So this is how ABG report interpretation is, done. Okay. Now, let's go forward with the step 3. मैंने आपके साथ दो step discuss किए. pH analysis, primary disorders you can identify. Let me tell you, these are the primary disorders, right? Now, step 3 is the compensation, guys. So the body always try to compensate, right? The body always try to compensate. So lungs compensate the metabolic disorders, and the kidneys are compensating further the respiratory disorders, right? Why? Because those are the areas to be fulfilled. So it is not like that respiratory will be compensated by the lungs. No, respiratory disorders are there because of the malfunction of the lungs. So who will compensate it? The kidneys are compensating for the respiratory disorders. Compensation is proactive and it is not a curative. This is very important understanding. And to understand this concept, I will say you will be having case at the end to relate this, and this will be showing you, the whole idea that how exactly the compensation mechanism is working. Should I explain right now or later? I'm a little bit confused, but yes, you will be able to connect the dots at the end, that how this compensation, works. So don't worry if it sounds confusing to you right now, but just understand that, this type of compensation mechanism without any therapeutic intervention is happening with the help of the body's own system. Okay, so this is the compensation. Next, we need to understand acid base disorders. Let me just give you idea about the compensation to you little bit, because I want to explain it. See, you need to understand this compensation, right? So understand first thing, compensation means the body's attempt to reduce the damage, okay, not to cure the disease. Understand this line first. Compensation means the body's attempt to reduce the damage. Now what compensation actually means? So when the one system, causes an acid base problem, another system tries to balance it. Another system is trying to balance it. So if the problem is metabolic, the lung try to compensate. If the problem is respiratory, the kidneys are trying to compensate. Okay, so body never overcorrects. It only tries to bring the pH closer to the normal range. Not, perfectly normal, but it is trying to match the closer value. So how lungs are compensating, metabolic disorder? Suppose if the patient has, let me just give you idea. Suppose the patient has metabolic acidosis, like a diabetes, ketoacidosis, very big complication of diabetes, right? So understand, if the patient is having metabolic acidosis, just for an example, diabetic ketoacidosis, what will happen in this case? Diabetic ketoacidosis has bicarbonate, which will be very low, right? Bicarbonate will be very low in the ketoacidosis, and blood become acidic, right? So this, I hope you have a little pathophysiology clear in your mind about the diabetic ketoacidosis, as this ketoacidosis is one of the big complication of diabetes, and it is a metabolic disorder, right? So what happens in this scene? Bicarbonate will be low, and the blood becomes what? More acidic in nature. Now the lungs are responded. Now the lungs will respond to this by breathing, faster and deeper, and blowing out more carbon dioxide. This is compensation mechanism. Why this has happened? Because carbon dioxide forms acid in the blood, right? And this is called one very important and one very important terminology is there for breathing. It is knowing as some technical breathing by the lung for the compensation mechanism. So it will be deep, rapid breathing seen in this diabetic ketoacidosis. So next time if you have seen a patient with diabetes ketoacidosis, try to correlate it with the lung pattern. Okay, you will be always having deep, rapid breathing seen in the DKA cases, right? And lab pattern always show you pH will be low, bicarbonate will be low, partial pressure of carbon dioxide will be low because of compensation. So this is compensation I am talking about. Lungs are compensating the metabolic disorders like diabetic ketoacidosis. I hope now it is making sense. Okay. And how kidneys are, making compensation for the respiratory is also the same way. Like metabolic alkalosis is the example to understand this. So patient is, for an example, suffering from vomiting. So patient loses, lots of fluid in it. So it is also considering a metabolic disorders, and in also this same lab parameters you will be having. So same compensation mechanism with the different organ is happening uh, with the body system. Now, this kidney compensate the respiratory disorder is also a very important concept to understand. For understanding this line, we will be having COPD example for an example. I hope you have idea about COPD, right? Chronic obstructive pulmonary disease. So patient, cannot exhale the CO2 properly in this COPD condition. Carbon dioxide increase, blood becomes acidic. So kidneys will compensate here by what? By retaining bicarbonate, right? So this is a compensated mechanism kidneys are doing for the respiratory disorder. So this is how, compensation works. I hope it is making sense now. What is compensation? So you must be having idea about this pH analysis, second primary disorder, and compensation mechanism body is doing by their own without any therapeutic intervention. So you can use certain medicines that can push this compensation mechanism. Okay, and you can convert this protective approach into the curative approach, right? So you can put some medicines for pushing your own system to meet the need. That is the reason behind analysis of step 3. You will be having in the case studies, so that will be clear picture to you. Now, let me move forward with the section 4, which is the acid based disorders you must be knowing. So, some of the metabolic acidosis you must, aware of. One of the very common causes, I just give you the example of diabetic ketoacidosis. We have renal failure, lactic acidosis. These all are considered as metabolic acidosis. And what is the pattern? Again, it is an acid, right? Low pH, low bicarbonate. So next time, if you are understanding the ABG report and you are seeing the low pH and low bicarbonate, always think about some metabolic acidosis situation or the risk of this metabolic acidosis. And next is we have metabolic alkalosis. So exact opposite situation. It is very common in excess vomiting, hydration, right? And the diuretics use, AC inhibitor use, prolonged use of this diuretics and AC. And this is often associated with the hypokalemia. Potassium level will be dropped. So that is the condition of alkalosis. In this, pH will be high, okay, and bicarbonate भी आपको ज़्यादा मिलेगा. So this is how metabolic alkalosis is categorized. If once you know the concept, it is very easy to differentiate metabolic acidosis and alkalosis. And what is respiratory acidosis? Let's understand. So this is occurs due to hypoventilation. Okay, hypo decrease ho jana, right? Very common with the COPD. And central nervous system depression is also common with the respiratory acidosis. इसमें क्या होगा? It is acidosis. pH will be drop. Okay, pH will be drop, and it is respiratory. That means partial pressure of carbon dioxide that will be also less, right? So this is respiratory acidosis. Opposite condition, respiratory alkalosis. This is causing, that causes includes anxiety, sepsis, pregnancy. These are the respiratory alkalosis. Again, basic, that means pH will be high. Okay, partial pressure of carbon dioxide, you will be having fluctuation in it, right? So this is respiratory alkalosis. Now, I hope you can easily categorize these conditions. Okay, and these are acid based disorder, guys. Metabolic acidosis, these are basic related, base related conditions which is required metabolic and respiratory, two different things to understand it, right? So this is again a very important concept you must be knowing. Now this is one of the case study to correlate everything all together. Now see here, the case is having high glucose, low pH, low bicarbonate, and high potassium. What are your judgment is saying? This is ABG report. Glucose is high, pH is low, bicarbonate is low, and potassium is high, what will be the situation? Anyone else? Whatever four situation we have been learning till this slide, just imagine. Okay, I'm happy by your answers. Yes, yes, yes. It is metabolic acidosis. I hope next time you are seeing ABG report, it will making sense now that how exactly this is relating. And it is the case of someone has written it right. It is the case of diabetic ketoacidosis, as I have mentioned, high glucose, right? So this is how diabetic ketoacidosis person's profile is look like. अब नेक्स्ट टाइम अगर आपको डायबिटिक कीटोएसिडोसिस डायग्नोसिस पता है तो यू कैन अज्यूम लैबोरेटरी थिंग्स. इफ यू हैव लैबोरेटरी थिंग्स विथ यू कैन अज्यूम डायग्नोसिस. Isn't it? Yes. Okay, next case we have this. Now, I already mentioned this because of your understanding. It is common, so I hope everyone has idea about it. This is a case of acute kidney injury. क्या होगा इसमें? Creatinine will be higher, EGFR will be falling. It is acute kidney injury and it is often associated with the hyperkalemia. So in this particular study, drug doses that must be adjusted. Now, this AKI case is very easy, but ABG report interpretation is little tough. But AKI is obviously you can imagine it by looking at the creatinine, EGFR, and hyperkalemia things, right? And this is the case of hyperkalemia to understand. So, hyperkalemia means obviously potassium will be above 6.5 MEq per liter, and this is case of an emergency, guys. If it is above 6.5, it is emergency. It is a red flag. Okay, immediate management requires. And what you can how you can manage it? By calcium gluconate, insulin with glucose. This is how you can manage hyperkalemia. For that you need to understand potassium metabolism, right? So this is the case study of hyperkalemia to understand what is the management it includes. Now, integrated interpretation, you need to understand, never interpret labs in isolation alone. It is not making any sense. Always correlate clinical condition, what is the history of the drug patient is taking, and trends over time. Okay, so pattern trends you must be knowing. Always interpretation needs this. So, what are the key takeaway from this whole module? Remember always, renal function test protects the kidney, electrolyte protects the heart, and the ABG reflect the life status, right? So, lab is only giving you the reports and the numbers, but interpretation requires clinical judgment, right? So, this is the end of the session. I think today's session is not that lengthy, but yes, it is very important, and I'm impressed by your answers in the chat box, that yes, you are listening to me, and yeah, you are understanding as well. So any questions from your side? Any questions from your side? No questions? If you want access to unmute yourself, just raise the hand, I will give you access. I hope this session makes now sense to you, and it is uh, it is now the importance is clear. What are the monitor for metabolic acidosis? Metabolic acidosis means low pH and low bicarbonate, and monitoring is done to identify the cause, assessing the severity, guiding the treatment, preventing the complications, and all. Right? Arterial blood gas parameter you need to monitor. That includes pH, bicarbonate, partial pressure of carbon dioxides, and serum electrolytes like potassium, sodium. Okay, and there is one formula also available for calculation of this. So you can use certain formulas also to do this. How do you manage respiratory disorders? Management of respiratory disorder needs another 1 hour to discuss, but let me just give you idea about it. So respiratory conditions are categorized further based on the laboratory things, and every respiratory condition has different therapeutic approach, right? So according to that, yes, we have algorithms as well to manage it. We have guidelines as well to manage. Okay, so based on that, we can try to, yes, manage the respiratory disorders. Respiratory alkalosis and acidosis. Yes, just now for your understanding, you just need to relate a laboratory parameters that suggest you the cases of respiratory alkalosis and acidosis. Pregnancy is always the special population category, and every parameter whatever we have been discussing, it will be different in pregnancy and the also in the older agent guy, older adult cases, right? So in case of pediatric population, pregnancy, lactation time, and as well as in older adult geriatric population, you will be having whole different scenarios with all the agents. You just need to aware that yes, we are excluding this population from, we are understanding from the general general, I will say, normal adult age scenarios, right? These are the special population consideration. Everything will be different for, everything will be different for that particular categories. So that must be clear to you. But I will be coming up with one more short course on, special population dose calculation and what to look forward with. Main difference between ABG and VBG. Okay, ABG is arterial blood gas, while VBG is venal blood gas. So ABG is artery focused, VBG is vein focused, and ABG is more painful. I can say VBG is less painful. That is the difference, but yes, it is depend on what we need to elaborate. So ABG is best for pH, partial pressure of carbon dioxide, oxygen saturation and all, while VBG is good for venous carbon dioxide pressure, bicarbonate, and also it is good for pH. Okay, I hope it is making sense. Okay, one more question, very important. Why anticoagulants are required prior to ABG measurement? So, what happens if anticoagulant is not used? When arterial blood is drawn, no, it naturally starts clotting immediately. So, if clotting occurs, blood cannot be analyzed properly, gas diffusion is altered, right? Analyzer tubing can get blocked. These are the reasons. So, anticoagulant is essential to preserve, to this kind of situation. And generally, heparin is being used. I hope it is clear. That is a simple mechanism to understand. Compensation, how to check compensation, that requires a step like identifying the primary disorder based on the pH, right? Then ask who should compensate, like metabolic problem, then lung, respiratory problem, then kidney. Step three is check if expected compensation is present. Like if the metabolic acidosis is there, expected compensation will be lungs, lungs hyperventilate and PaCO2 will be, decrease. Metabolic alkalosis hai, तो expected compensation will be again with the lungs. So respiratory acidosis will be again, compensation will be done by the kidney. So you need to check bicarbonate, right, level. So this is how you can decide. But if you are in the field of pharma, this is not your area of concern. But of course, you should know that how they are doing it. Okay. So then you will finally decide that no, it is no, partial or full compensation is required. And there is also one very important rule that, compensation never overcorrects the pH, guys. Acidosis will not become alkalosis, and alkalosis will not become acidosis, because when you are correcting it, there is always the risk behind this is that. And if the pH, crosses over, then it is a mixed acid base disorder. Another thing to discuss. Okay, any more questions? Still, if you are, seeing this recorded session later, and if you have any doubt, feel free to drop message in the WhatsApp chat. Also, you can drop query in person as well. I'm just a message away. Don't worry. Okay, if no question is there, we can wind up for today and see you guys tomorrow. We will be having a very important session tomorrow. Okay, Friday. And we will be discussing microbiology reports and antimicrobial interpretation. Very, very important. We will discuss gram strain basics, MIC values. Timing will be now from tomorrow onwards. I have two sessions actually today on the Thursday. That's the reason we have another course, the Advanced Antimicrobial Stewardship. That was the reason. But tomorrow we will be having on a regular time, 7 to 8:30. Okay. Okay. Thank you so much, guys, for joining today. Thank you. See you tomorrow.